Thanks, Imogen, and thank you for inviting me today. So I'm just going to talk about something different, the staging, and particularly I'm focusing on the new staging. So many of you will be aware the American Joint Cancer Committee updated their staging. This is now the 8th edition that we're following to manage melanoma. So this is an evidence base. It's actually an update of the 7th edition, which was from 2010. So what they've done is looked at all the data from the 7th edition, but they've also added in data, because as you're all aware, management of melanoma has really revolutionized in the last 10 years. So since the development of the 7th edition data, we have a lot more information. So what they did was put together the 7th edition data together with an international melanoma database, which is actually across 10 centers internationally, US, Australia, Europe, and then also included the clinical trial data. So most recently, over the last 5 years, some quite important big clinical trials, the data that's come from that has also been included. So taken together, we're looking at over 50,000 patients have been included in this evidence base. And so the report was actually published in October 2016 in the Cancer Journal for Clinicians. It's part of the American Cancer Association. But actually, they recommended that it shouldn't be implemented until January 2018. And so in the United States, it's been implemented formally earlier this year. I think in the UK, you'll find that many centers are also starting to utilize this new staging. So many of you will be familiar with this. This is a summary of the 7th edition. As I said, it was published in 2010, and that's if you look at any trials or if you look at any studies, basically most of the, all of the patients that will be staged will be based on this staging. So just to bear that in mind, that looking to the future, of course, this new staging is going to be slightly different, and I'm just going to highlight those differences today. So the staging is, and I'm sure many of you are familiar with this, but essentially the staging is divided into a TNM classification where you stage the tumor, you stage the nodal status, and you stage whether there are metastases or not. And then you get a prognostic stage. So the prognostic stage is stage 1A or 1B and so on. So looking first at the T classification, the T part of the staging, so the tumor. The first thing to say is that the tumor thickness measurements, previously we were measuring to 0.01. Not all centers were measuring to 0.01, and some pathologists were rounding up and measuring to 0.1. But what they've said in the new guidelines is that you should really be measuring the thickness of the primary tumor, so this is the Breslow thickness, to the nearest 0.1 millimeter. And if you look at T1, so this is tumors that are less than 1 millimeter thick, they've now subclassified this into T1A, which is a tumor which is less than 0.8 millimeters, and T1B, which is either less than 0.8 millimeters and is ulcerated, or more than 0.8 but less than 1 millimeter and can be ulcerated or not ulcerated. So the reason that they use the 0.8 cutoff at this point is because when they looked at all the data together, it does appear to be important, this cutoff, for whether you're offered sentinel node biopsy or not. If your tumor is less than 0.8 millimeters thick, the chance of a positive sentinel node biopsy is less than 5%. If the primary tumor is between 0.8 and 1 millimeter, then the chance of a positive sentinel node biopsy is between 5 and 12%. And their recommendation from the 8th edition was that patients with a Breslow thickness of greater than 0.8 should potentially therefore be offered sentinel node biopsy. The difference between this staging and the AJCC 7th edition also, you will notice, does not include the mitotic rate. So mitoses is basically a measure of how active the original primary melanoma is. And in the AJC 7th edition, anybody who had a thin melanoma which had mitoses would upstage their tumor. And in this new classification, mitoses has not been included. So this graph just shows the survival, and I'm just going to mention mitoses because people do still talk about it, and certainly mitoses are an important factor in terms of how active the melanoma is, but is not an independent factor compared to the thickness of the tumor or whether your primary melanoma is ulcerated or not. So this survival curve just the curves basically show you the survival for those patients that have melanomas that have a certain number of mitoses. So the pink line is no mitoses, and they've grouped both the stage 1 and stage 2 melanomas in this graph. And then the brown line, is the primary tumor has more than 11 mitoses, so very active. The cells are turning over a lot. Now, mitosis is measured by looking under the microscope, so this is in the original primary tumor when it's removed. And you can see that there's a difference, so that if you have no mitoses, the chance of your melanoma spreading is certainly less than if you have lots and lots of mitoses. So it is important. We are still looking at this when we examine the primary tumor, but it doesn't upstage you if you have mitoses in your original primary melanoma. So what does this mean? Well, so in 2017, if you had a melanoma that was 0.9 millimeters, non-ulcerated, and had a mitosis, but you had sentinel node biopsy and this was negative, you have a T1b and your prognostic stage is 1b. So at that time, a T1b would mean that you had a stage 1b. In the new edition, the same patient has a T1b, but actually this is now called prognostic stage 1a. So it actually downstages you. It suggests that those people who had this melanoma, which was originally thought to be a stage 1b, probably do better than it was originally thought. So this has implications. So it doesn't change things in terms of whether you're considered for sentinel node biopsy or not. It does change things like your follow-up. So certainly in the UK, current guidelines are that if you have stage 1a melanoma, you're only seen for a year, whereas if you have a stage 1b melanoma, you're seen for much longer. It also means it slightly changes what we say to you when we give this diagnosis, because previously we would have said, well, actually there is a certain proportion chance that this is going to come back, whereas if you have now the same tumor, actually we've looked at all the information and it looks like that chance of melanoma recurring is much less. And so actually downstages the melanoma. So this is quite complicated, but it's just worth bearing in mind that in the old system, it's not identical to the new system, and that there is these group of patients that will be upstaged or downstaged, depending on what changes have been made. So the next thing to talk about is the N. So remember, there's a TNM classification. We're looking at the nodal. So this is definition of the regional lymph nodes involved. If you have no nodes, then it's N0. And then if you have nodes involved, it's N1 if it's one node, N2 if it's 2 or 3, and N3 if you have 4 or more nodes. The first thing to look at is the A classification. So NA category, these are what are classified as occult, which means that the nodes are only identified microscopically. So you can only have an A category if you've had a sentinel node biopsy and you've identified that there is a node involved. NB is clinically palpable nodes. So these are nodes that are identified by palpation and that you felt that there's something there. And so then you'd be upstaged to an N1B or N2B or N3B. The C category is a new one compared to the old classification. These are non-nodal, loco-regional metastases, and of which there are actually 3 categories that you could have. So this is not necessarily nodal involvement, although it is included when you actually look at the staging. But specifically, if you are talking about the non-nodal metastases, the first type of non-nodal metastases you can have is a microsatellite. So this is where in the original primary melanoma, when it was removed, not actually in the tumor itself, but next to the tumor or near the tumor in that specimen, usually in the wide local excision specimen, you can see some melanoma deposits within that specimen, and that's only seen under the microscope, so it's called a microsatellite. The satellite metastases, so this is either deposits of melanoma in the skin or under the skin, so cutaneous or subcutaneous, but within 2 centimeters of the original tumor when it was removed. And then in-transit metastases, so these are deposits of melanoma which are beyond 2 centimeters away from where the original primary was removed. And usually this is in the direction of where the next possible node may be involved, but it can sometimes occur in the opposite direction. So, for example, for this melanoma, usually it's up towards the groin, but it may be that you see things in the opposite direction towards the foot. So this NC category, so this is a new one, basically it is a bit more complicated because if you have the microsatellite or in-transit metastases, you will automatically be a C classification, but the numbers of nodes that are involved, as well as having those three, determines whether you are N1, N2, or N3. So if you're N1C, you don't have any lymph nodes involved, but you do have one of these non-nodal deposits. If you're N2C, you've got a node involved, plus you have one of these. And then if you're N3C, then it's two or more of the lymph nodes involved, but you also have one of these non-nodal. And so this is a survival curve just showing why they've added this in. So the pink curve just shows survival for patients who have melanomas where you don't have any of these, don't have in-transit metastases, and don't have satellites. And then the green curve is the in-transit metastases, the orange curve is microsatellites only, and then the blue curve is in-transit plus microsatellite. And you can see that they all are quite similar, but certainly if you have any of these, the chance of the melanoma recurring is higher than if you had none of these. And so that's why they've grouped this, and there seems to be some importance from all the data that we've collected that actually if you have any of these sort of deposits of melanoma outside of the original primary, that they will upstage you. So moving on to metastasis. And so the metastasis, the M category, M0, of course, is no evidence of metastasis. M1 is distant metastasis. The first major change is that in the old classification, we did know that lactate dehydrogenase levels in the blood, the LDH levels, are important. They determine the sort of degree of tumour burden within the body and reflect that. And previously, they had stage 4 as a classification, and then if you had an elevated LDH, so if you had high levels of LDH in the blood, it was a stage 4C. In this new classification, that's been incorporated into all four parts of the M1 category, because we know that if you have an elevated LDH, it doesn't matter where your metastases are, this is probably important and would upstage your disease. So the M1A is metastases, so melanoma that spread to the skin or soft tissue. The M1B category is melanoma that spread to the lung, which could be including skin and or soft tissue. 1C is any other organ that's affected, but not the brain or the spinal cord. And then M1D is brain or spinal cord involvement with or without any of the others. So just thinking about the prognostic groups and summarising this, there isn't an overall change in the T categories, but as I mentioned, the stage 1 and 1A and 1B are slightly different from previously. So to be a stage 1B, you need to have a primary melanoma which is greater than 1 millimetre thick in terms of its Breslow thickness. The N categories have slightly changed. Stage 3 is certainly a lot more complicated than the previous classification, and I think that's important because, of course, stage 3 disease is gaining a lot of attention at the moment because of the use of adjuvant therapies. So this chart is actually in the paper, and it's quite complicated to follow, but essentially it's not quite as straightforward as previously, where you could sort of easily work out which stage, substage within stage 3 you have. So essentially across the top you would work out which T classification you have, then across the side you'd work out what N classification, and then you'd be able to work out whether you're stage 3A or 3B or 3C. Stage 4 is not further substage, and as I mentioned, so previously there was a stage 4C, and this doesn't exist anymore. If you have elevated lactate dehydrogenase levels in the blood, that upstages you regardless of what part of stage 4 you have. And so the reason for having the 8th edition is that we now have these quite nice, distinct, separated curves for survival. So the pink curve is stage 1A, the green one is for stage 1B, the orange is stage 2A, the blue is stage 2B, and then the brown is stage 2C. And you can see there's a difference. So as you go up in the stages, the chance of your melanoma coming back starts to increase. And this is the breakdown across all stages. And I said it's a little bit more complicated than the 7th edition now, and particularly in the stage 3 category. So it's not quite straightforward. And for those of you that can see, it doesn't go stage 3 A, B, C. It's actually a bit more confusing, and that's why they have that table. The new category is stage 3D. And I mention this because stage 3D, of course, for all the adjuvant studies that have previously been done, these patients would have existed, but they would have come under a stage 3C or a 3B. So if you are now classified as a stage 3D on the new 8th edition, actually you have to look through the data to work out what old edition staging you were, to determine whether you were eligible for trials or whether you weren't, or whether you, how you would have benefited potentially from different treatments. So this does slightly change things. The stage 3D are essentially very thick ulcerated tumours with a number, more than 4 nodes involved. And so these are the graphs for the stage 3, where 3A is green, 3B is blue, 3C is orange, and then 3D is the red curve. So the 3D, we do now know, and based on the data that we have, that this group certainly are very separate to the 3A, 3B, and 3C. And then the final point I just want to make is that just thinking about adjuvant therapies, particularly, as I say, because this is a group of patients who, you know, are receiving a lot of attention at the moment. We will hopefully shortly be receiving some guidance about who will be eligible to receive adjuvant therapy. And the one thing I would say is that in the past, the majority of patients that have been offered adjuvant therapy are within the stage 3 group. But of course, if you superimpose the stage 2C group, so these are patients who have very thick ulcerated tumours, but you don't have any nodal involvement, you can see that actually that dotted brown line is actually coming slightly below stage 3B. So there have been studies where patients with stage 2C have been offered adjuvant therapy. Looking at this, looking at the new guidance, looking at the new staging, I think that these patients potentially could benefit from adjuvant therapy. I mean, we have yet to see what the criteria are going to be for offering adjuvant therapy, but it is worth just bearing in mind that although all of the attention is on the stage 3, the stage 2C patients also have a high risk of melanoma coming back and therefore potentially could benefit from this. So thank you for listening, and apologies if this was quite a confusing presentation.